let's fast forward let's say 5 years in an optimistic state of mind. Psychedelics, maybe psilocybin is now FDA approved. Maybe, and I think there's a very good chance that it is. Maybe ibogaine is edging closer to being approved. Stellate ganglion block therapy, which is a very powerful, very effective, very valuable treatment, may become more widely recognized and used. Right now, it's just ignored because guess what? Psychiatrists don't prescribe it, don't do it. Big Pharma doesn't do it. It's neurology. Okay, so let's say psychedelics, stellate ganglion block. Let's say we've enlightened ourselves a little bit about the importance of tracking hormones. Now we may be in a revolution. Now that's going to have to disrupt because now we're not going to need all these therapists. Now we're not going to need all these prescribers of psychiatric medications. So some of their work goes away and gets reallocated over to these other modalities.
You're listening to the Born Primitive Podcast.
Well, morning, Chris. How we doing?
I'm good. How are you?
Coming in from Hawaii?
Yeah.
Jeez, it's a long trip.
Yeah. Thanks for having me, though.
Well, we're stoked to have you, and so many directions we can go with this one. But I think just to get right into it, I know you've been in the field of the veteran community 30 plus years, with the last 10 being specific to the special operations community. So I guess I'll give you a very open-ended question to start out. But over the last 3 decades, what are the biggest takeaways you've learned from your research, and maybe paint the picture for the evolution from 30 years ago to where we are today? I think, at least from my optic, a lot of progress has been made as far as understanding kind of what's going on. But I think you would probably agree there's still room to, there's still ground we got to close on that. But curious from your perspective, since you've been able to witness it for 3 decades, the progress and just unpack it a little bit for us.
Well, I think so. I got my PhD in clinical psychology in 1992 and went right into my first job was at the VA working with veterans in a PTSD clinic, where I was a full-time clinician for the first 7 years of my career. Looking back, so what was that now? That's 33 years. It's a long time. In terms of the knowledge base, we've advanced quite a bit. We know a lot more than we knew in 1992. We have developed technologies. We cracked the human genome in 2000. We know a little bit about things. And we know so much more about genetics, so much more about sleep and the physiological aspects of what's happening with sleep, and why sleep is so important. So we've from a scientific perspective, I would say we've got an incredible advance in the knowledge base with some huge gaps, massive gaps. We know very little about traumatic brain injury. We know not much at all still about genetics, other than genetics really, really, really matters. I think we have a long way to go in understanding how to kind of train and tame the central nervous system. While I've seen massive changes in the science, what I have not seen are any real changes in the practice of mental health care. And I think that's the tragedy of where we're at today. I don't think the VA as a system is providing any better treatment to veterans typically than they were 30 years ago. Traditional mental health care is pretty stagnant. It's still almost entirely a bucket of psychiatric medications, which haven't really changed much since the early 1990s, and psychotherapy, which, while we know we've advanced some understanding of psychotherapy, it hasn't really, the practice of it, I would say, actually has gotten worse in a lot of ways. And we can go down that path if you want. And we're leaving a lot of the really good treatments completely on the sideline. We're going to get there with psychedelics, I think. That may be the big disruptor for the mental health care field. We are not using a lot of the technologies and interventions that we should be and can use very effectively. We do almost nothing with hormones still. So, in my 15 years at the VA, from 92 to 2006, myself included, we never referred anybody to have a hormone check. We were not looking at hormone panels. The VA still to this day doesn't want to do that. DOD medicine doesn't want to do that. Civilian general medicine for all men and women doesn't do that. And I would say that is one of the big failings. We should be looking at hormones for every patient.
If you were king for a day,
yeah, I'd love to be.
With no restrictions on budget, what would it look like? What would a 360 kind of solution look like? You obviously mentioned a lot of opportunities,
right? Well, so I would use the operator syndrome as a framework.
Yeah, and can you frame that up? Can you summarize that as well?
Yeah, sure. Let me start there.
Yeah, let's start there.
Okay,
and then how you'd fix it and what the perfect program would look like.
For the day, man, I do a whole bunch of stuff. We'd have some fun. So the last 10, 12 years, I've been working primarily with special operators from Navy, Army, Marines, Air Force, Canada, and a smattering of operators from other countries, as well as a lot of private defense contractors, many of whom were formerly come from special operations. Many, got there via SWAT or other law enforcement. And in the last couple of years, I've been working more with law enforcement, firefighters, high-risk professionals. I'll be out with the DEA in Southern California next week. So the concept of the operator syndrome and it's a framework, not a specific medical diagnosis. So the framework includes traumatic brain injury, hormonal dysfunction, and I guess I'm talking about the pathologies, but we can flip this around and talk about them as domains to look at. So in special operators, we see high rate, and I'll just put it this way, for your average Navy SEAL, and when I say average, 90% who have more than a few years in, traumatic brain injury, low testosterone, other hormonal dysregulations. We have insomnia, just general sleep dysregulation, circadian disruption, sleep apnea. That's something we never used to look at. I think we're still not looking for that enough. Chronic pain, headaches, cognitive, impairments that go with everything, insomnia, hormonal dysfunction, TBI. And of course, anger, depression, anxiety, general anxiety. Yeah, there's some PTSD in there too. We've way overestimated PTSD, and I think that's part of the tragedy of modern mental health care. And we can come back around to that. Perceptual systems, so impairments in vision, hearing, balance. What else? Addiction, and then so all of that is So part of what I'm saying here is physiology. I put a huge emphasis on physiology. And the mental health field puts psychological stuff forward with physiology in the background. My view is we need to reverse that foreground, background perspective. Physiology should be forward, and we're not doing that. And then, of course, we have the effects on all of the human physiological systems that then cascade into the social systems. So marriage, parenting, work, social, community. And then the existential issues that are very prevalent in high-risk professionals. So I just framed everything from the perspective of pathology. If we think of each of these as domains just to be curious about for each individual patient, that's what I think we should be doing in mental health care for everybody. Let's not start with the assumptions that if you're looking sad and you're tired and you're fatigued and you don't have much motivation and you don't feel like yourself, I don't think we should assume that that's major depressive disorder and immediately hand you a prescription for Prozac. We should take a step back and go, well, wait a minute. Let's check out some of these other things. How is your sleep? Are you suffering from chronic pain? What's going on if you're a man, what's going on with your testosterone? And, I've seen this over and over again. Guys who were diagnosed with depression, PTSD, prescribed psychiatric medications, given a therapist, or referred to a therapist. And then it turns out that's not their problem. they have low testosterone. When we treat the testosterone and it comes back up into a normal, healthy range, all that other stuff starts to clear out.
Yeah, that makes so much sense because I remember in my first platoon, a bunch of us had to get testosterone prescriptions out in town because and it wasn't like guys were running in the 800 range and wanted to just get huge.
Right.
I think we had 8 or 9 guys go get tested. I was one of them, and we were all like below 300 or right around 300.
Yeah,
right?
like 80-year-old men.
Yeah, and this is like a bunch of pipe hitting alpha males that if you looked at them, you'd say, yeah, these guys are high T.
That's right.
Yeah, and then we had to hide it. You know what I mean? Like I remember going on deployment. I was putting testosterone vials in my blowout kit. You know what I mean? Like I had a second blowout kit, and it's like, how absurd is it that I have a prescription that's optimizing my hormones so I can be a better operator? Yeah. That I have to now smuggle on a deployment because if they find out, heaven forbid, they're going to say it's PEDs, which is, to me, it was completely absurd because I was thinking, if I were king for a day when I was an operator, I would have said, okay, every guy here is going to be on a complete program with a professional that this is what they do for a living. And because this is so critical for our job, we're going to get blood work, every 2-3 months, and you're going to make little tweaks. Hey man, maybe your testosterone dosage is a little high. We're going to bring it down, or hey, it didn't quite, and all the other things that you can, give with it. So every guy's on a specific program, but it's in a controlled and safe environment. Not, this guy's going to some guy in town that wants to give him way more than he needs. You know what I mean? And he's now running at 1,500 on his testosterone. Now he's mad at everyone, or whatever. You know what I mean? So it to me, it was such an obvious thing. Look, let's run this like a professional sports team. If like that was allowed within like, WADA regular, you know what I mean? But it's like, hey, we're not competing in sports. So why are we acting like this is like, you got to not talk about it? I mean,
and SOCOM likes to say humans before hardware. Performance is everything. That's all we care about. You got to perform out in the, on deployment. Why would we not take every possible opportunity to give you every edge? It's just astonishing.
Exactly. Well, especially when you look at from like a technological standpoint, it's like we exploit everything imaginable on the battlefield. We got night vision goggles, we got ISR overhead, we got infrared lasers, all these things. We got comms where we can with multiple comms you can run multiple channels.
You don't get to wear body armor because that's cheating.
Exactly. And then down at the operator level, the most important part, they were like, you better not get caught taking testosterone. It's like it is literally the biggest disconnect, and I can't wrap my head around it. And I think they've made progress now, and maybe you have more visibility into. But I think NSW did some sweeping, like they said, we're going to start testing guys with like a WADA level test. Yeah, and it's like, who? I'm sorry, but what admiral that wants to get another star on his sleeve or shoulder? Like what? Where is that coming from? That is the complete opposite of what they should be doing. Because now guys are going to freak out and they're going to get off of testosterone. They're going to go back to 280 and they're going to feel like shit. Yeah. And then all the effects that you are more versed on than me are going to happen. Right?
And they're not going to perform.
Yeah.
As well as they otherwise.
So it's just, it blows me away. Yeah. And I feel like someone that needs to take over that's innovative and doesn't see it as, that's like performance enhancing drugs. And it's just, but I don't know if that'll happen because, it's like, at a certain level of leadership, it seems like they all just turn into politicians. It almost becomes like prehistoric. It's like, oh no, that's, they're like 40 years behind. And that's the scary thing about the psychedelics too. Tony and I have been big proponents of that. We just had Brian Hubbard on, which is incredible. We see the obvious impact that can have, on everyone, but specifically the veteran community and first responder communities. But that they'll be 50 years behind on reacting to that. It's kind of wild. So guys are going to have to, go down to Mexico. They're going to have to take leave and claim they're going on vacation with their wife, and really they're going to do Ibogaine in Mexico and getting reset and maybe saved. But they got to, again, it's kind of like the testosterone. They got to hide it.
So let me just interject 2 points. One is testosterone supplementation may not be what everybody needs. There are other ways to raise testosterone, oftentimes. So there's like Clomid, there's dietary supplements, there's rest and recovery protocols. So not everybody's necessarily going to need testosterone supplementation. The other point I wanted to make, and this gets back to when I get to be king for the day, is one of the things that I think has really sabotaged current mental health practice in America and probably all throughout the West is the ideological takeover, the progressive ideological takeover of medicine, but especially mental health care. So I think the testosterone is actually a part of that. We now have the American Psychological Association has an ethos now that part of why they exist and why psychologists are trained is to promote social justice. And psychologists are supposed to promote social justice, whatever the fuck that is, in each and every individual patient. And they have guidelines for boys and men that a lot of what's in those guidelines is about leaching the masculinity out of boys and men to make them more feminist, more effeminate, whatever. Yes.
How?
And social work and psychiatry have the same ethos now. So we send a young man or an old man to therapy. They're almost certainly, 80% of therapists now are females. Most of them are progressive, politically progressive at the ideological level. And so they don't want you having higher testosterone. They're perfectly happy, I think. I mean, I'm being very cynical here, but I think there's an ideological perspective that masculinity bad, testosterone raises masculinity, ergo testosterone bad.
Well, ironically, we're filming this on June 6th, the D-Day anniversary. And my rebuttal to that is say, no one wants toxic masculinity until we got to send 6,600 ships across the English Channel and, start an invasion to save the world.
That's right.
So that shit drives me crazy.
Same.
That blows me away that it's infiltrated into like the clinical psychology. Oh. Like how is that even relevant? You're really infecting that when someone's just trying to get better. Yeah. I don't want to go completely off the rails, but man, that threw me for a loop.
Well, they've gone off the rails, so we could talk about that. There are counters to that now, and and that's the good news. It's not 100%, but that's the challenge that men in general and certainly high risk professionals are facing.
Do you remain optimistic for the VA, or do you think like almost a parallel system is going to have to be created? Meaning, that is such a large entity with so much bureaucracy. Do you remain optimistic, having firsthand experience, kind of seeing how they continue to kind of, I don't want to say drop the ball, but in a way drop the ball on and allowing any innovation to take place within their treatment of veterans? I'm
not in the VA and haven't been for almost 19 years. I'm still recovering from my escape. The VA, and listen, I enjoyed working at the VA. I really did. I loved the experience, the patients I worked with, the people I worked with for the most part. The reason I left the VA really had more to do with the leadership coming down from way above. And what I would say about the VA is they do some things really well. Some veterans I know say they get good primary care at VA. I know some veterans who have specific acute combat injuries, and they feel like they're getting good care there. What I think the VA has done, it's a complete and utter fail, is the mental health program. So you have the largest mental health program in the world nationally. Well, I think it's 14, $15 billion a year. They can show no evidence, and I mean zero evidence, that veterans are getting better from the mental health care. And part of the reason for that is every veteran who deployed gets diagnosed with PTSD. You went overseas, you're not doing well, PTSD. That's the great big shiny red easy button. Boom, PTSD. Now we don't have to do anything for you other than give you a therapist, give you a bucket of psychiatric medications. And if you're not careful, you'll end up on 10, 15, 20 medications. That's no joke. I know I've met veterans frequently who not on that level of medications any longer, but were at one point. And the therapy isn't provided by people who necessarily know anything about the military, don't necessarily have any cultural competence. It's a phrase we throw around a lot in psychology. They don't know what does a Navy SEAL do. They don't know what does a Green Beret do. They don't know what people in any of the other combat arms do. And they don't even know that there is a combat arms separation from support personnel. Now, everybody who put on a uniform, they served, they stood up for their country and full respect for that. But they don't all have the same experiences. They don't all have the same injuries. And the VA treats everybody the same. And there's this automatic assumption of PTSD and of trauma. You served, you're traumatized. You deny the symptoms of PTSD. Well, you're in denial. I get that a lot. Oh, well, I say, well, the operators I work with, very few of them actually have PTSD. They don't have the fear reactivity. They don't have the avoidance of cues that might remind them of their military experiences. And then they come back on that as well. They're just in denial.
How did you as you transitioned out of the VA, I'm assuming at some point, or you were having did you have a grand kind of disillusionment with the work you were doing, or was it a slow transition where you recognized that maybe some of the parts of the system you're involved in were broken? And how did you learn to think critically and not get caught up in the momentum of well, this is what I was trained to do, this is how we're going to treat it? Was that a long evolution, or were there some very acute moments that led to that?
I think there was an evolution in the mid-90s when I realized or noticed, and it was something that we all talked about, all of the patients coming into the PTSD clinic were applying for PTSD disability. And what we found was they were coming in, the veterans coming into our clinic, kind of all were reading from the same script. Several things that were very prominent, that were very notable, was if you diagnose somebody with something other than PTSD, the patient would get very angry. They didn't want to hear that they had depression or general anxiety and not PTSD. So that's a red flag. They would often say, thank you, doc, I'm getting better or feeling better, but please don't write that in my medical record because I don't want to risk losing my disability, which is a rational perspective to have. And so I don't blame the individual veterans. I blame the system for creating an incentive to turn veterans into psychiatric invalids, which I think is just tragic, absolutely tragic. PTSD is treatable everywhere else in the universe. But when you pay people to be sick, how do they get better? And then, as I was publishing some research, series of studies starting probably in 1998 through 2005, showing high rates of symptom exaggeration or fabrication, we published a study in 2005 showing a very high rate of dishonest reporting of Vietnam experiences. So, it was a small sample. We took 100 consecutive veterans, got their DD-214s matched, which you can get through Freedom of Information Act requests. And we matched them up with what they told us. And the disconnect there was unbelievable. Only about, I don't remember the numbers, but it was somewhere between 25 to 30% matched up according to what they said.
Yeah, it's an interesting topic.
And from there, what happened was really interesting. And that became the reason why, ultimately, the main reason why I left was the VA didn't want to hear this. Shut up. I got investigated for that study. They did a witch hunt. They looked for every possible little I that I might not have dotted, T I might not have crossed.
They investigated you because you were looking into basically fraud within the VA. They didn't like that?
They did not like that. That's right.
Why?
Well, so here, maybe this is the big point. There is a PTSD industry within the VA. You've got empires built around PTSD programs. You've got a network of national centers for PTSD that have, an ungodly amounts of money. They're congressionally funded, so nobody can touch them. And, and I worked with these people. I was not an outsider when I was in the VA. I was publishing a lot. I had federal grants. To this day, I just got a thing a few weeks ago from some organization that tracks research productivity. And my research on PTSD puts me, and sorry for the brag here, but in the 99.8 percentile of PTSD researchers in terms of the impact of my research and the publications. My point is I was one of them, but this work made me not one of them. And so my mentor, who at the time was one of the top people in the field, he was a director of one of the national centers, called me on the phone one day and said, listen, you just submitted this paper, referring to this paper on the showing the dishonesty in terms of combat and military experience. He called me and said, and this would have been 2004, 2005, and he said, you submitted this to the American Journal of Psychiatry, somehow got into my hands, which isn't supposed to happen unless he was a reviewer. He said, you got to retract this. You got to pull it back. You can't publish this. Well, why? Because it's going to hurt it might put our funding at risk. It might put our funding in jeopardy. And I said, yeah, but it's legitimate research. It's an important issue. He goes, well, it's a small sample size. Yes, it is a small sample size, but it's a pretty damn strong signal, don't you think? And maybe that means we should take a lot bigger look at it. Eventually, that paper got published in the British Journal of Psychiatry, which is one of the top journals. American Psychiatry didn't publish it. So we went to the Brits because they don't have the same politics. They published it. It got a lot of national, international attention. So that's when the VA really got mad, because The Economist, Washington Post, New York Times, Wall Street Journal, like it kind of blew up. And they assigned a handler. So I had a PR handler who had to follow me around. I could not do an interview without getting permission first. She had to sit in on the interviews, and she had the power to strike a question that I was asked. She had the power to strike a response that I gave. And that's when I left. My mentor actually said to me, not only did I have to retract it, but he said, if you don't retract it, your career as a scientist will be over. He said, I won't throw you under the bus, but I won't be able to protect you from, the other forces that will be coming at you.
I feel like this general theme comes up a lot with, there are bigger things at play that ordinary people like us aren't seeing.
You can't see it.
And you're,
right.
You're alluding to PTSD centers, and I think probably big pharma has a
big pharma, and the PTSD industry that's embedded in every VA hospital.
And some of it probably was well intended at some point.
Sure.
If, a PTSD center, like that'd be like, okay, right on.
Absolutely.
And Congress funding it, like
made sense in the 80s.
But it's like, man, when you peel back a few layers, and I love, obviously you exposed it with what you did. If you're stacking up a DD-214 with a guy who's saying he has all this combat trauma, and you're looking at it like, no, you didn't. And if it was enough, instances to have external validity for a study, like why would they not be like, well, hold on, I'll stop this.
Nope.
We need to refine the SOPs.
Right.
When someone comes in to do their out processing,
which would be a simple thing.
We're going to have it. Doc's going to be like, okay, and he's going to be looking down and, oh, you were never here. You know what I mean? And instead, they almost want that diagnosis.
It's what we now understand as the deep state.
Deep state.
I didn't have that phrase in 2005. I didn't have that concept. But when you think about how much money was at stake, and still is, it's the same. A lot of the same people, if not the same dynamic, are still in charge, and they're still providing the same mental health care, the same failed mental health care, and they don't want to be disrupted. So really what we're talking about right now in terms of, so back to me being king for the day, we got to disrupt the big pharma and the PTSD industry. They need to be disrupted.
Well, there's and this has been a theme we've talked about at length, is that there needs to be a transition from viewing humans as like commodities. And in this case, it's almost as if the victim archetype is perfect because you get your claws into it. And then guess what? They're reliant on big daddy, whatever system that is. So let's use big pharma. They become reliant on it. What's flipping that on its head is that people and systems and governments are set up to actually foster humans to being the best version of themselves. Now that may sound trite, but genuinely, that's what government and systems, meaning healthcare systems, should be doing. What has happened is it's ironic is that it's the literal opposite of that, meaning let's shove them into a victim archetype and what we're talking about, meaning you have PTSD. It can't be anything else. Let's not check your sleep, your relationships, your diet. Like it can't be any of those things.
Yep.
Yeah. It's got to be this thing that you went overseas. And then, as you said, people become dependent on that, which I can actually relate to that more. But then systemically, as that spreads, and that's not just the PTSD industry, that's the food industry, that's so many of our systems. And what Bear always disagrees with me is that, like, I actually am optimistic that we're going through a bit of a revolution there, even in the psychedelic space. Now, there are certainly some hurdles that are going to have to get over to get there, but I am seeing some things and some momentum that make me optimistic. Now, the VA one, that's outside of my realm. But that's why I kind of asked the question of, do you remain optimistic?
Yeah. Well, so let's fast forward 5 years and be in an optimistic state of mind. Psychedelics, maybe psilocybin is now FDA approved. Maybe, and I think there's a very good chance that it is. Maybe ibogaine is edging closer to being approved. Stellate ganglion block therapy, which is a very powerful, very effective, very valuable treatment, may become more widely recognized and used. Right now, it's just ignored because guess what? Psychiatrists don't prescribe it, don't do it. Big Pharma doesn't do it. It's neurology. Okay, so let's say psychedelics, stellate ganglion block. Let's say we've enlightened ourselves a little bit about the importance of tracking hormones. Now we may be in a now that's going to have to disrupt, because now we're not going to need all these therapists. Now we're not going to need all these prescribers of psychiatric medications. So some of their work goes away and gets reallocated over to these other modalities.
It's just what, since we just had Brian Hubbard in, the same themes came up with him. He was working with the state of Kentucky. And for some reason, the governor and the attorney general didn't want this to advance, even though, you know what I mean? And there was all this built in. It was obvious what it was. You know what I mean? There was corruption, and the big pharma doesn't want a solution to the opioid pandemic, right? So it's just like,
follow the money.
Yeah, exactly. Right. So, Tony, like I'm just not as optimistic when there's billions of dollars to be made, what men will do to make billions of dollars. That will ruin most people's moral compass, right? The only way I see the solution is if the Eli Lillys of the world are the ones now facilitating the ibogaine and the psilocybin, and then they'll say, oh yeah, we're all for it.
Oh, then it
right?
explodes.
Yeah. Right. And so then they just made us all sick for 30 years. And then as soon as they realize there's a solution that is undeniable now, they're just going to pivot. And I don't know the specifics of Eli Lilly. I'm throwing one name in the mix, but we can zoom out to big pharma in general. To me, that's the only way you actually shift to a solution, and then they'll find a way to corrupt that.
But
you know what I mean?
The issue is that doesn't work, because if you do psilocybin not that there's an absolute correct way, you don't need to do it for another 6 months.
No, I know.
But their model works great.
But Tony, they'll figure something out. Like, you know what I mean? Because like that is the irony of it. Hopefully it's a one and done, especially the ibogaine.
Sure.
It's not you take this pill every morning and they just cash in. But at least at the very least, I think there's more awareness, and I think more people like us are a bit more cynical towards just the obvious like conflict of interest that some of these large entities have in, the balance of, they're just trying to maximize profits, and 99 times out of 100, that is not in the best interest of the people actually receiving what's on the end of it. And we have to take the good with the bad. The good of big pharma is because there are incentives to make billions of dollars through research and developing new drugs. Well, guess what? When you go to the hospital, or when you have your toddler at the hospital in the ER and they have some infection and they have some drug that cures it and you're out of there in a day. Well, modern medicine, the reason those drugs exist because there was a massive financial incentive for them to research a cure for that. So in a way, it's like, guys, we got to kind of take the good with the bad a little bit. But I think there's a lot of bad, and obviously the opioid pandemic and all that, and just the absurd, obvious, intentional, sinking their teeth into people that were vulnerable to get them addicted. And then just all the second, third order effects that came from that, just devastating communities. Yeah. So it's just, it's a lot to wrap your head around, but specifically within the VA, it blows me away. I mean, I really appreciate you sharing that, because I always thought, Doc, that like most of it was from people coming in with their little script saying, oh, I have this, and they know what to say. And, you know, from my perspective, that's pretty infuriating, because there's guys and girls that actually did the job and actually saw stuff.
That is a reality. I mean, that is there. That is there.
But I didn't realize that on the other side of it, they were like encouraging that. You know, I would think there would be a doc on the other side who'd roll his eyes and say, yeah, I've heard this before. Hey, you're a support personnel. You never left the wire. You can't tell me you have PTSD from that vehicle-borne explosive device that blew up 2 miles from the fob. You don't have PTSD. Like, nice, you know, you read from a script that somebody gave you so you can get your disability, but get the hell out of here. Instead, oh yeah, this is perfect. Now I can prescribe you this, and we get another. You know. So it sounds like it was, rather than the docs being a gatekeeper to truth and saying, well, hold on, you know, was that really traumatic when that thing blew up 2 miles from your base and you never would, you know, have worn body armor? Like, because there's real stories of this from, you know, support personnel that worked with us. Yeah. And all of a sudden we're like, wait a second, like how is that a thing? You know, and so, you know, it's just, to me, it's obvious fraud. I just didn't realize it was being almost encouraged on the other side of it.
There's a very deep collusion going on there at the level of the grassroots clinicians. Now, it's not all of the clinicians. Yeah. And so you certainly have clinicians who are trying to push back on that, but they don't have any real power to do that.
Yeah.
Because veterans can reapply, re-adjudicate their disability claims indefinitely, for one thing. For another, clinicians in the VA, as I understand it, are not allowed to look at social media. They're not allowed to obtain a DD-214 through a Freedom of Information Act clinically. We did it in a research project, but we didn't translate any of that over into the medical records. So none of that got into, you know, like that didn't affect the individuals in that study.
How would you, so let's play a scenario, because I had, as I mentioned, I think we were off air, I had the honor of going down to the Mission Within and seeing 5 veterans in our group that like had just the anger that they showed towards the VA, because these are the individuals, almost like the archetype of what you've been talking about. They've had 10 different prescriptions, have been tossed around as far as their 20 year guys who did 20 years in the service, and then have been actually the one did 35, and then have just felt like they've been pinballing around the VA. Finally found the Mission Within, which I watched their transformation take place while they were there. But the question for me is, if you're one of those individuals, so let's say you're 50 years old, you did 20 years of service, let's say during GWAT, where you were seeing real, or not, I don't want to say real, but like combat deployments, and you've kind of pinballed around the VA. What are some like everyday things you would recommend, maybe on like the hormone level or like the sleep side of like, okay, check these boxes on your own, but then setting up a system for knowing what I know, here's what I would explore if I were you, if you're frustrated with the current care you're getting.
Yeah. Well, so if you're in the combat arms, if you have any level of training with the explosives, jumping out of airplanes, combat deployments, what I would do is I would print off the operator syndrome medical paper, go through that with which is easy to find online. I'd go through that with a highlighter, highlight anything that seems like a need, and take that to my primary care doc. And then this is a lot of guys do this, and it seems to be effective. They take it in, and the primary care doc gets reoriented and goes, oh, okay. They don't know what a Navy SEAL does. They don't know what a Green Beret does. Not really. They have no concept of the training. They don't know what the training is. They think everybody kind of trains the same, you know?
We're all Jason Bourne, right?
You're all Jason Bourne. They don't even know how Jason Bourne trained. So that reorientation often works. Then the primary care doc goes, oh, okay, I see. Now I have that gives that doctor not only a little education and awareness, but also what they need to be able to justify, because the system doesn't want them referring you to get your hormones checked. They don't want the system. They don't want, maybe sleep studies now are easier to get. I think they probably are, but a referral to pain management, behavioral pain management, not pain pills, but behavioral management of pain. A lot of guys are finding that works in terms of being able to kind of juke the system a little bit. and get outside the traditional psychiatry, psychology, social work, nursing, mental health nursing into other avenues. And there, if they get to see an endocrinologist, if they get to see a neurologist, then they're getting care that's more close to what they may need.
Yeah, I think just to close out like the VA part, obviously I was a bit cynical of it, but on the other side of the coin, for guys and girls who are listening that have a very physically demanding job, particularly the special operators, a lot of guys, the problem is a lot of guys like us, Doc, are like, oh, hey, I'm good. Like, you know what I mean? I'm not, I'm a little banged up, but I'm good. And they get out and they don't get much, looked at. Mm-hmm. And then 10 years later, you're walking around feeling like the Tin Man because you got all this stuff that, because you were still active and because you have high pain tolerance and you're just a hard dude, you think you're better. And I got really lucky that the doc at the command I was at when I was getting out, he was actually a former SEAL turned doctor. So he was running the medical thing. So when I went down to him to start my out processing of medical, he said, all right, here's what we're going to do. How are you feeling? I'm pretty good. I'm a little banged up, but I'm good. That's probably the answer I gave him. You know what I mean? And he said, no, you're not.
No, you're not.
So he said, we're going to image every main joint that you have. He said, how are your knees? How's your shoulder? They're okay. How's your back? And so they x-rayed basically every joint and then they MRI'd every joint. And when I got it all back, I was blown away at what I actually had going on. Mm-hmm. So right shoulder, I had a rotator cuff and labrum. I thought my shoulder, it was sore occasionally, but no issue. I thought no issues. Lower back disc problems, upper back disc problems, torn labrum in my right hip. My right knee was super like pre-arthritic or whatever. Like they could see it was not doing great. And then I went up to Fort Belvoir and did all the stuff up there and they did a brain scan and there, a bunch of white matter on my brain, things like that. I did just under 8 years, and compared to guys that did 20 with a heavy operational tempo, I'm nothing. Like, you know what I mean? And that was just me. So imagine what these guys that were really doing the job and getting after it with a heavy op tempo, what they look like. But unfortunately, and I think it's gotten way better now, a lot of guys, I think it's because of pride and just because we're tough and, oh no, save it for the next guy, end up not doing that, and you don't even realize how banged up you are. So I want to make sure we turn the coin over on that, because you have the people coming in that do 4 years in a support role and all of a sudden are claiming PTSD and knee problems and all this, but then you have a 25-year door kicker who's a patriot and says, hey Doc, I'm good, and they're on their way, and then 5 years from now they need that knee surgery, or the shoulder is really hurting, which is ironic because for me, my right shoulder is now giving me a ton of problems, and I know what's going on in there. But
in fairness to that 4-year enlistee who was a support personnel, they did important work, and they may legitimately have real injuries and real health needs, but it's going to be completely different from the very unique types of long-term accrued injuries that special operators and other people who've put in 20 or more years, 15 or more years in the combat arms, as well as law enforcement firefighters who do 20, 30 years in their careers. The way I view it, what I would say is it's going to be inevitable. It's the cost of doing business. You can't walk away from a high-risk professional career without having physiological injuries throughout the physiological systems in your body. Your gut's affected, your brain's affected, your respiratory, your cardiac, your musculoskeletal, your endocrine systems, they're all interconnected, right? So if you injure your brain via blast exposures, that's going to have an effect on everything else.
We haven't touched on that area too much, kind of the gut microbiome, and that's one, I can't remember his name. We had a doctor on who went deep into that, not within the vein of veteran health, but are you seeing that's a field from an outside perspective that I've seen kind of boom. You would probably know the name because he was the first one that started saying like, hey, there's a connection between your dopamine levels and your gut. So how do you see that field evolving, and do you see enough attention being put on that within kind of the diagnostic world of like, well, how's your digestion? How's your gut microbiome?
Mm-hmm. Yeah. And your metabolism, all of that's interconnected. That's a largely uncharted frontier right now, and it is ripe for us to now start to understand it. Somebody you might want to talk to is a good friend and colleague of mine, a psychologist named Alok Madan, who he's at Houston Methodist Hospital, and he was the second author on the operator syndrome paper with me. But that's his career. When we were colleagues at the Menninger Clinic in Houston, Texas, and I was the research director, one of the things we did was we started collecting fecal samples from every patient that came into the hospital. And we worked with a microbiologist at Baylor College of Medicine, a guy named Joe Petrosino. And so we brought together and we published our first paper in 2020. So this is not even new. But we looked at the nexus of the sequenced bacteria, the DNA and the sequenced bacteria and the psychiatric symptoms and the recovery from those symptoms over time. There's a very powerful connection between psychiatric status, gut microbiome, which of course makes sense. I mean, your brain and your gut are connected. The vagal nerve and other nerves. You've got neurotransmitters and neuroreceptors in your gut. The gut is kind of like the second brain.
And I guess what are things on a practical level, like that we can do to
eat right?
You just okay.
Fucking eat right.
And for knuckleheads like us, what do you typically see that we're doing wrong in our lifestyle?
Well, probably not you so much, but Americans in general, we eat so much processed food.
Okay.
And it's processed foods, it's fast food, it's sugar, it's soda, it's fast foods. You know, one of the things that I talk about and when I do workshops or when I work with police and firefighters is you guys got to eat differently. Well, that's a real challenge if you're in a squad car, a patrol car, or in a station house. But eliminating all that crap has such a benefit. And then eating whole foods, eating, clean, clear, good proteins, can just be profound. The way to view it is inflammation. And so this is kind of what I put a lot on in terms of lifestyle adaptations, living an anti-inflammatory lifestyle, which means cutting out all the fast food, junk food, sodas, sugars, eliminating or at least reducing alcohol and tobacco, prioritizing sleep, getting good, appropriate exercise, which most Americans don't do. That will bring you a long way to wellness, and it will reduce the inflammation in your body, which is a driver of all of the chronic diseases that plague us in the modern world. Diabetes, depression, cancers, autoimmune disorders, respiratory illnesses, et cetera, are all driven by chronic systemic inflammation.
We've lost even and this is more the granola side of myself, but like our connectivity to food, meaning and this is something I've explored deeply of even eating healthy, but if you're on your phone, you're high paced the whole time. This is something and this is a little more nuanced, but playing with, put on some, and here's the granola side of me, put on some classical music, sit down and chew your food until it is a liquid, and do that with every bite, and tell me you don't feel completely different as the way you digest that food after.
Yeah.
And they're I say we've lost our connectivity to food because everyone's on their phone. They just had a coffee before they're eating, and they're like, well, I'm eating healthy, but my gut's still messed up. It's you're not even, you're shoving food down your mouth and then expecting your body just to assimilate it. It's the way in which you eat, the timing of which you eat, how you eat. From my experience, I won't say it's as important of if you're just to eat processed food in that way, but it's a significant driver of how your body is processing food.
Family dinner.
Yes.
Sitting with your loved ones while you break bread is something we used to do. Normally, that was just a normal. Now who does that? I
love Brazil's. Now, I need to verify this. I heard this and I may have read it. Their equivalent of their health agency is a one-line statement of what they recommend. And it says, eat real food with people you love. And I was like, that is awesome.
That is awesome.
To boil things down into one line, it's eat real food with people you love. Because like you said, there is eating, talking, having a real dinner and sitting down and giving your body time to not just shove food down your guzzle. It makes a difference.
Yeah.
Well, I love what your approach to this, Chris, leading with the physiological first. That's the first time I had heard it kind of in that context. And I think that is so spot on because the pill is maybe the 10th option on a sequence of all right, let's get this dialed in first, because if you got a guy coming in, getting 5 hours of sleep a night, eating a bunch of fast food and a bunch of sugar and all these other things, and then says he's depressed. Well, it's like, no, dude, you just feel like shit because you're treating yourself like shit.
Right.
Like you're trying to run on a function on a high level and look at the intake. You know what I mean?
Right.
So I think getting back to the fundamentals, especially like sleep, like that's right. That's one right off the bat. And
Sleep,
I even
diet, exercise, social meaning in life,
and purpose. Yeah.
Purpose.
Because I even kind of will check myself on that occasionally, because I would say I'm a little bit of a biohacker. I got the cold plunge at my house. I have the infrared sauna. I take some peptides. I have a bunch of supplements that, so yeah, am I kind of a little bit of dork at that? But hey, if I'm getting 5.5 hours of sleep a night, oh, cute. You did the cold plunge when you woke up, but you're running, you know what I mean? So I think it's important we don't forget the fundamentals. And I think once you master all of those, yes, can those other things enhance that final 10%? Yes. Yeah. But you're an idiot if you think, oh, I'm healthy because I'm cold plunging, but you're drinking a half a bottle of wine every night and getting 5.5 hours of sleep and not having a balanced diet. Right. And then you go to the gym, you over caffeinate because you're a meathead, and then you compensate, and then it's like, so it's this weird, like, I think it should be built from a foundation. And I love how you reframe that, because most of us are not a green in all of those areas. You know what I mean?
I'll give another phrase that's that's about the physiology. It's allostatic load. If you're a high risk professional, you have high, massive allostatic load, which is a hypothetical phrase, or it's a phrase that refers hypothetically to all the burden on your physiological systems. And high allostatic load is cumulative. So you had 8 years of accumulating high allostatic load associated with your work. No way around it. I mean, you've got sleep deprivation, you've got circadian disruption built into your work. I mean, it's inevitable. It's there. You've got that high operational tempo, which guarantees that your cortisol and other stress hormones are always elevated. So that's just there. It's inevitable. But what do you do about it? How do you manage it? How do you tame it after you're retired? How do you manage it while you're still working and active to optimize your performance?
Yeah, and I'm curious to dig into that a little bit. And this is more just kind of for my own personal awareness, but I'm sure a lot could relate to this. But I think from being a SEAL for almost 8 years and just what that entails, I think it kind of hardwired me. I don't want to say you're always on edge, but there's always kind of something that's stressful to, that you're, you might be in a specific block of training and it's specific to that. Maybe you're in the kill house for a month straight and live rounds and guys in the rafters grading you. Like it's high stress. Mm-hmm. Not only do you want to be proficient for your peers and reliable, but you also, there's a safety component, you know what I mean? You're live rounds and then you go to a jump block and now you're jumping 3:00 in the morning, doing night jumps, and then you go VBSS and you're climbing up ship ladder. I mean, it's like it continues to shift and evolve, but then there's just an incredible amount of, I would say, peer pressure. Now it's a good pressure, but it still is, you need to be
undeniably massive pressure,
especially for, guys that are new guys, and you're never really safe, for lack of a better term, even literally safe, when you're doing high risk training, right? Or of course getting deployed, but also kind of like you never, even when you're like in the platoon space hanging out, you never really feel like you're, so for me, that was, 7+ years of my life. And of course, like, I'm not even getting into the schoolhouse, like for our training, you talk about paranoia, fear, anxiety. I wonder how much, and particularly like in buds, like now that I'm 37 years old and I've been removed for a couple years, I still feel like I carry a lot of that anxiety and just that heightened alertness that I don't really like, because it's like I'm perceiving all these fictional threats everywhere. And it's like, dude, you're like, that life is over, but I can't turn that knob down. Okay. I'm trying. Okay. And I did the psilocybin and, I do the breathing and the meditating, but I'm almost wondering, okay, what else have you just been hardwired that, and that's just how you're going to be the rest of your life, or over time, will that, dialed down. And I think there's good and bad. You know, I'm kind of illustrating the bad part of it, but it also, I think, can lead you to be, you know, help be a high performer just because you're just
right.
You're just kind of amped up and a little bit more ready to get after it. But then there's this side, I'm like, man, just, you need to chill, like relax. So I guess, could you, since your background, how do you like dissect that? I'm sure that is not unique to me.
Yeah.
But even going back to like, you know, this is silly, but we talked about PTSD, and maybe this isn't how you classify it, but even for, you know, guys that didn't see crazy combat or anything like that, like I would argue like the training we went through in any selection program, like I think describing it as traumatic is accurate. You know what I mean? Mm-hmm. You know, like for our crew, we had over 200, we had 11 originals graduate. Like there's no way a bunch of motivated grown men could be that many can be eliminated if you don't produce a traumatic, horrible experience, because everyone there wanted to be a SEAL. So in order to have only 11 make it, you have to do some crazy, horrible shit.
Yeah.
And no one, I think, would admit that, oh, the training was traumatic. But I think a lot of my behavior now, and maybe the anxiety, and it is rooted in when you're just a student and you're getting woken up at 3 a.m. with a bullhorn to go jump in the Pacific Ocean. It's 53 degrees and bear crawl with, you know, scuba tanks on your back and all this crazy shit we did, because you go to bed and you're like, well, hey, I might get woken up in 30 minutes. And you're constantly on edge. I mean, you know what I mean? So how does that play out for, again, that's not original to me, I don't think.
So yes. So hypervigilance, which is often in psychiatry, psychology is thought of as a symptom, as a psychiatric symptom. What I would say is hypervigilant, and it's a symptom of PTSD and other anxiety. What I would say is hypervigilance is a adaptation. You had to be hypervigilant. That was a survival mechanism for you. You wouldn't have made it through training, let alone combat, and let alone deployments. So your physiological response nervous system has been reset to be at like an 8 or a 9 on a 10-point scale, let's say. Your baseline is high. And when your baseline is at an 8, like my baseline is probably a 2 or 3 most of the time. I have a very easy, cushy life. I sit on a couch or on my porch or at a desk most of my life. In fact, nowadays I rarely leave my house because thanks to Zoom and all the other technology. So I don't have a high, but you do. And so if you're at a 7, 8, 9 habitually, chronically, that affects you in a lot of ways that you probably aren't even aware of. I mean, your fingers are moving a little bit right now. Earlier, your feet were moving a little bit. That's normal. What does your family see? What do your friends see? Are you always present with them, or are you sometimes expending energy to be aware of what's going on around you? If you're a first responder, how could you not be, vigilant when you're out in the community for threats, for perps, for things that could happen? What does that do to your sleep? How long does it take you to fall asleep when you lay down?
3 minutes.
Same, maybe less.
Okay.
Yeah.
Okay. That's awesome.
But I think it's like when I get home, I'm exhausted.
Okay.
I'm exhausted.
Okay. So you're physically exhausted.
Yes.
And do you do anything once you turn out the light and your head is on the pillow? Do you do anything to help yourself sleep faster?
I don't need to, because I'm out in under like a minute.
Okay.
It sounds like Tony is too.
Okay.
That's fortunately that's never been an issue, like the sleep side.
So no racing thoughts, no mind churning and burning.
Every once in a while, I'll get, if it's if I had a unique stressful event that day, I might. But usually, because I'm so exhausted. Well,
here's a thought, and I would just kind of offer this out to everybody who's listening. It may not work for you. It may not be specific for you. You may already have tried it, but stellate ganglion block. Stellate ganglion block is a way of resetting your central nervous system to bring that physiological arousal from a 7, 8, 9 down to a more normal baseline where most of us are at, 2s, 3s, 4s. And it's literally involves an injection of medicine into the stellate ganglion nerve, which is the sympathetic nervous system. So physiological. It brings that medicine takes effect very quickly. I've got I'm hanging out with a friend tomorrow who's active duty right now, team guy at DevGru. I've been telling him for a couple of years, you should get the stellate ganglion block. And he did it about 3 months ago. And he called me that night and he was like, dude, I finally got it. Can't believe how relaxed I feel. Can't believe how calm. I can't even remember feeling this way ever before. Wow. And it's lasted, still to this day, 3 months later or whatever. It's a very powerful, effective way of bringing that anxiety down. So if you haven't had it, I would definitely look into it. One of the pioneers, a guy named Sean Mulvaney, former Navy SEAL, went to medical school, became a neurologist. And that's the thing. Who does this intervention? It's neurologists and anesthesiologists. You won't get it from psychiatry, which is part of the...
It's probably a good thing, huh?
Takes us back to where we started yes. earlier, is we've got this powerful, amazing treatment that we're not using very often because it's not provided by traditional mental health care. It's literally a treatment that's been around 100 years. It's not new. It's been used for treating headaches with Sean and his colleague, Jim Lynch, and others. And the other pioneers noticed that when they treated soldiers' headaches, and I should say this, Sean, after becoming a neurologist, went back to the Army and was working at one of the tier units at Fort Bragg. And he noticed that when they treated soldiers' headaches, which is what the treatment originally was for, that they came back a few days later and would say, I'm sleeping better, I'm calmer, my anger, I'm not angry, not as vigilant, hypervigilant, and everything in the world just seems to have slowed down. It's like I got a trip to Hawaii for a couple of weeks, and it's not going to cure everything in your life. It's not going to certainly not going to change your lifestyle habits, but it becomes a way of opening a door to opportunity to relax, to begin making some other changes in life. Typically, what we see is the benefits seem to last for somewhere between 3 and 8 months, typically. Sometimes much longer, and sometimes people never even want to do it again because they don't need to. 5-minute procedure, very safe. It works almost immediately, and it's very powerful for about 90% of the people who receive it.
Wow. I'll have to look into that.
Stellate ganglion block.
Okay. How do you, if you are somebody, using Bear, what is the approach? You said it's not a psychiatrist. That's just your general. That's the trick.
In fact, if you could ask your primary care provider.
Okay.
You can I talk about it in my book. I talk about it on podcasts every time I get a chance. And again, it doesn't actually replace traditional mental health care. It's actually should be used as an adjunct, as a starting point. Okay, let's get you feeling really good right now, today, and then you'll engage differently in other things that you're working on, other therapies. I would say do it before you go do it 6 months or 3 months before you go do a psychedelic treatment. Get a little bit right, get a little bit more relaxed.
Yeah.
Some spouses I talked to have described it as like an anti-asshole treatment.
There you go.
Ibogaine was described, a lot of the wives.
Yeah.
Well, because they're like, he came back a different, they're
he
like,
came back like a nice guy.
Yeah,
exactly.
Yeah. Well, hey, some of those wives can use it too. Let's call it both ways.
Question.
Let's call it both ways,
sure.
ladies.
And in fact, the Operator Relief Fund, which is a foundation that sends operators to get stellate ganglion, sends the wives too. So that's
good.
Part of what they recommend.
Nice.
Husband and wife together.
Little couples retreat.
Yes. Couples massage.
Do you have to go under to receive it?
No.
Interesting.
And it's a little freaky to receive a needle in the side of your neck. Around C7, C6. Some the better docs typically do dual-sided, so they'll do both sides. They can use, the procedure is essentially the same as when you go to the dentist and the dentist injects Novocaine into the nerve before they work on a tooth.
Yep.
It's essentially that.
Okay.
That's basically what they're doing.
Well, that's a great context. I had heard of that, but I had no idea what it was. So maybe I'll give that a go. Maybe I'll Be a little more chilled out here at HQ, Tone, huh?
Yeah.
What do you think?
I think it's we that caffeine dose.
Yeah.
That might be step one, is get that from like 700.
Well, hey,
to like
and those are, those are,
you're absolutely right.
yeah,
You're
and those are also real considerations.
That is real.
What are you putting in your body? And because some days I'm really tired, doc, or I have like, I look at my schedule and I'm in meetings all day. I'll take a half of Modafinil, which I think is like the generic Provigil. I just bite one in half. You know what I mean? And because and this will sound silly comparing it to these other jobs we're talking about, but like, at our normal day, Tony and I might be in meetings from 9:30 until 4:15. We're coming up for our first breath of air. And while it isn't physically taxing, the mental bandwidth that requires, and especially kind of, I would say, decisional effort when you're having to analyze something and receive it and kind of make quick decisions, and then you have to completely put on a different hat in your next meeting and it's something totally different, and that constant and then you miss lunch because you got double booked, and before you know it, and that's why when I go home, I'm like, I sit down on the couch for the first time and my daughter wants to play, and I'm just like, oh, like I am spent, and I have to now mentally get ready because like I don't want to be that tired dad that's like, oh, I'm too tired to paint with her or play tea party, whatever she wants to do, you know what I mean? So I kind of, when I'm driving home now, I kind of have to rewire, like, all right, the work isn't done now, the second job starts. I'm getting better at that now. I just can't sit. That's my death wish. If I sit on the couch, I'm toast. So that's what if I just stay standing.
When do you plunge? When do you cold plunge?
I would usually do it in the morning. I'm working. This thing keeps breaking, so that's throwing it off. But when I was in my best routine, I was doing the sauna and the cold plunge 4 mornings a week.
Okay.
And I kind of strayed away from it. But I did know that was a good. I felt that helped with my anxiety and my just overall feeling of well-being. And so I do think there's a physiological
those
benefit
are powerful recovery.
Yeah.
Those are really good. But there's randomized clinical trials that have shown that hot sauna brings down the chronic inflammation in your body, physiological, and it's literally an effective antidepressant treatment to do 3 hot saunas a week.
Okay. Is it okay to do infrared too? Because I have an infrared. I know there's battle between heat and the traditional.
I know less about infrared.
Okay.
So I don't want to say something stupid here. But probably yeah. We have a friend, Derek Gordon, in the Fire Ice Frogs.
Yeah. Speaking of.
So they push out to operators, Gold Star families, sauna and cold plunge. I did my first cold plunge a year ago with them at an all secure retreat, and Derek, got me in the tub and coached me through that process.
How'd you do? Just stick it out?
Yeah. I did 4 minutes, and it actually wasn't hard for me. I liked it a lot. I felt like it was one of the best drugs I'd ever experienced. When I got out that night, my sleep was amazing. My recovery was phenomenal.
And I think a side benefit from it, and this is probably more of a mental benefit, is like, I think the idea of waking up in the morning and doing something hard right off the bat that you don't want to do primes you to have a assertive kind of executive outlook the rest of the day. At least it does for me, right? If I'm more disciplined in the morning and I do something like that, I feel like I have an edge. And I think it's because I chose, all right, I don't want to do this. You never want to do it. At least I don't. I always dread it. But it's like, okay, get in there. And then once it's done, you're like, okay, I chose to do one hard thing. And when other people were sleeping in a warm bed, 44-degree water, trying to breathe through it. So I think there's
44 degrees.
Yeah, I usually have between like 44 and 47.
Kind of weak.
Oh, is it?
Yeah.
Oh, come on now. What are you running at? You did it once? Now he's busting my balls. Yeah.
No, I went home and bought my own system.
Oh, you did?
Yeah.
Oh, nice.
Yeah. I think I kept mine set at 40.
Oh, wow.
But I think as long as you're under 50, you get the full benefit.
Yeah, it's cold, but
I am just busting your balls.
Well, anything else we want to cover? I mean, this is, we went a lot of directions on this. We even put our tinfoil hats on a little bit, which I like. Yeah, we like to.
At this point, it's not even a tinfoil hat anymore.
Yeah, I know.
It's just kind of becoming known. But I want to get just the opportunity for you to plug the book. Anything else that you have out there that you'd love our listeners to follow along with?
So the book is a short book. It's not a medical book. I wrote it for you guys and your spouses. So it's written for operators and responders as just an educational. The first half of it is sort of here are the kinds of things that are probably going on in terms of the allostatic load and the way it's affecting your body. And then the second part of the book is the various interventions, both lifestyle and medical. So there's a section in there on a little chapter on anti-inflammatory lifestyle. There's a section in it on stellate ganglion block, on psychedelics, on transcranial magnetic stimulation. And while I'll take responsibility for writing the book and everything in there, I would say probably 20% of the words in the book are quotes from operators, from spouses, that to kind of bring it to life. So it's really intended to be like a 3 or 4 hour read, and you can start anywhere. You don't have to read it straight through.
Perfect. Well, Doc, thanks so much for coming and obviously making the trip you came from Oahu, right?
Big Island.
Big Island.
Yep.
Oh, wow. Well, that's a long haul. We surely, because it's still early in the morning, your time. So you're probably a little extra caffeinated this morning for this one.
No,
but, yeah.
No, I adjust pretty quickly.
Nice. Yeah. Well, thank you so much. This was all super insightful. And I know you're also going to be going on the Hot Wash podcast, Born From Tactical with Bruno, our host of that one. So I'm sure you guys are going to have an awesome conversation on that and go, a couple different directions. So if you guys like this episode, definitely check out the Hot Wash podcast. It'll air likely a month or two after this one airing. So just be on the lookout. Doc, thanks again for sharing all the plethora of information of you being doing this for 30 plus years.
Thank you for having me.
I think there's a lot of great lessons, but I think for me, the biggest takeaway is the physiological should be first, right? And I just think we all need to focus on that. How is our sleep? What are we eating? Physical fitness, purpose, like those things. Let's do that first before we allow someone to give us an antidepressant. And so I just, that was the first time I'd heard it framed up in that manner. And I just think that's all something we all need to be stewards of that. Because not everyone's educated. A lot of people will go into an office and get convinced they're depressed and give, you know what I mean? Like I'm fortunate that I get to speak with guys like you. And then when I was in the teams, we're around that environment. So we're more educated on some of these things, but the average Joe Schmo that is working at, blue collar 9 to 5 and doesn't, you know what I mean? He might go in and get diagnosed and now he's on, a litany of medications that he doesn't need. So I think we need to all try to be stewards of this, and get the word out. So, the powers that be that we already discussed can't continue to sink their hooks into us, and kind of dilute who we are as humans and, you know what I mean? And just become zombies on some of these drugs. Right. So, to me, that was the biggest takeaway. And I appreciate you sharing a lot of that information.
Thanks for having me. It was a great conversation.